introduction. Right? I'd like to invite our chairperson, Dr. Jayanta Kumar Das from Guwahati, to please come up on the dais and take the chair. I'd also like to invite the co-chairperson, Dr. Sonal P. Yadav from Pune, to please come up on the dais and co-chair the session. And everybody, I am Dr. Sonam from Chennai, and I'll be moderating the session on socket. In the interest of time, let's start and get started with this. And I'd like to invite our first speaker, a very dynamic and young Dr. Mritika Sen from Mumbai, who will be joining us very soon in Chennai. And she's going to be talking about evisceration and enucleation. I'd like to request all the speakers to please stick to the given time, and we can take questions at the end of the session if we have time. Thank you.
A very good afternoon to all of you. I'll be talking about enucleation and evisceration, which I like to call losing a game but winning a battle. So to most people, these are disfiguring surgeries which deviate from the goal of vision preservation, which is for ophthalmic surgeons. But is that really so? Well, it depends on the indications and the techniques with which we can maintain both cosmesis, and in some cases, this may actually be a life-saving procedure. So the 4 M's that will help you to achieve a good cosmetic result includes operating under a microscope or a loupe, ensuring minimal manipulation. You put in an implant whenever you can, except for specific reasons where you can't put it in, the choice of implant, and finally, all these 3 things together contribute to the motility. So coming to the indications for enucleations, these are irreparable trauma with no visual prognosis, and prevention of sympathetic ophthalmia, a chronic painful blind eye, objectionable appearance with staphyloma or an atrophic or thicycle eye, and intraocular tumors, most common of which are melanoma and retinoblastoma. What are the things that we need to take care of before we start the surgery? First and foremost, check, recheck, and check the eye again. Dilate both the eyes and do an indirect ophthalmoscopy to confirm the eye before you start the surgery. Of course, these are even more important when we are operating in a case of retinoblastoma or an intraocular tumor. You have to ensure minimal manipulation. Do the myoconjunctival technique. I'll come to that. I'll show that in the surgery. Avoid any kind of accidental perforation and avoid using clamps for optic nerve. A long optic nerve is a prerequisite, which includes 15 millimeter. This is for intraocular tumors, specifically retinoblastoma. So some of the basic principles that would help you achieve good cosmesis ensures to preserve the conjunctiva, prevent any sort of buttonholing, and you do the peritomy very close to the limbus. Secure the wound in 3 layers, that is the posterior tenons, the anterior tenons, and the conjunctiva to prevent complications related to the implant. And you do an optimal volume replacement. So the implant has to contribute to 70% of the ocular volume. So this is a short video that shows the enucleation that was performed for a 3-year-old child with retinoblastoma group E in the left eye. In case of children, we like to do a canthotomy. This gives more space so that we can get a long optic nerve stump. The instruments that we use specifically for retinoblastoma should be blunt tip to avoid any sort of perforation. You do the peritomy flush to the limbus, and you do this we are operating under the microscope. The posterior tenons dissection is done again with a blunt tip tenotomy scissor. It is done in all the oblique meridia. After this, we start tagging the extraocular muscles. So the order is medial rectus, inferior rectus, lateral rectus, and superior rectus. We pass a 6-0 silk suture a little away from the insertion because that is the thinnest part of the globe. Then the muscle is tagged with 6-0 vicryl, about 6 to 8 millimeter from the insertion, and we cut. We can use RF cautery, or you can also use an artery forceps and cut it with scissor, but you leave a stump of at least 1 millimeter close to the insertion. Otherwise, when you're giving traction, the sutures can come loose. After this, we have to disinsert the oblique muscles, that is the inferior oblique and the superior oblique. Once that is done, we need to prolapse the globe, and I'll just fast forward to that. You prolapse the globe. With this, what happens is the optic nerve is absolutely straight, and you don't really have to pull on it too much. Then you go in with the 15-degree curved tenotomy scissor from the lateral side. You strum the optic nerve till you're able to touch the bone at the orbital apex. You open it just to enclose the optic nerve, and you cut with a single cut. This ensures a long optic nerve stump, which you, of course, have to measure, and then you put in an appropriately sized implant. This is the closure of the posterior tenons. You do it with interrupted 6-0 vicryl sutures, and you take time for the closure because this is a crucial step that will avoid complications in the post-operative period. Following the closure of the posterior tenons, we need to reattach the muscles that we had tagged to their respective fornices. This is the myoconjunctival technique, and with this technique, it ensures adequate motility, which is almost equivalent to that of an integrated implant that has not been pegged. After this, we close the anterior tenons, again with interrupted 6-0 vicryl. And finally, we close the conjunctiva with a continuous key pattern of suture. So, I'll move on to the next slide. Post-operatively, whatever you take out from the globe, you have to send it for histopathology. That is very important because that decides the need for any adjuvant therapy. You have to follow up the patient for the other eye as well as for systemic evaluation, specifically for oncology cases. And then you implant the prosthesis after 6 weeks after allowing the socket to heal. So just a small bit about the size of the implant. The usual rule that we follow is the axial length of the normal eye minus 2 millimeter. But if we are wrapping it, then in that case, we need to subtract additional 2 millimeter. Apart from this, clinically, you can check for mooning intraoperatively, and you can also use sizers. Coming to evisceration, the indications in this case are a normal-sized blind eye, an enlarged or a staphylomatous blind eye, in case of endophthalmitis and panophthalmitis, or expulsive hemorrhage. Now, generally, this is a relative contraindication, atrophic or thicical eye, where you may not be able to achieve adequate volume if you're going by the traditional technique alone. These are, again, relative contraindications, history of prior trauma or via surgery, because the laser and the cryotherapy kind of keeps the choroid firmly adherent to because of the scarring to the sclera, and it becomes difficult to separate it out in one piece. A painful inflamed eye because of the risk of sympathetic ophthalmia, and a thicical eye because of an unknown origin, or if there is extensive calcification. Of course, we have to do a B scan with immersion and a UBM to rule out intraocular and ciliary body tumors before we decide on evisceration, a CT scan or an MRI whenever that is necessary. The implant in case of evisceration is smaller than what we use for enucleation. So usually for an eye of 24 millimeter axial length, we put in something like a 16 to 18 millimeter implant. However, there are techniques by which you can implant a bigger size, you can put in a bigger size of implant. That includes sclerotomy, that can be radial in the oblique meridia, or you can do a circumferential one. I'll show that in a video, with or without optic nerve transection. The 4-petal technique, and by these techniques, you can either keep the implant partly or completely exteriorized. So this was a 38-year-old male with a blind eye following trauma. Again, the steps of peritomy remains the same. You try to preserve as much of the conjunctiva as possible. You need to do just the anterior tenotomy in this case, and you don't need to go up to do a very good posterior dissection. You do a stab incision, and then you take out the corneal button. Following that, you need to put in the evisceration scoop, and there's a cleft between the uveal tissue and the sclera, and you need to go all around, separate it completely from the sclera, and then take it out as far as possible in one piece.
I request you to please conclude.
Yeah, I'll just sum it up. And then, so basically the steps are the same, but we have to treat it with absolute alcohol. And following the wash, you put in, so here we are doing a radial sclerotomy, but if the size is still not adequate, you can do what is known as a circumferential sclerotomy, where you go in up to the equator and you cut all around, leaving the muscle. So that allows you to cover a larger implant with the sclera, and then the closure remains the same as for enucleation. Thank you so much.
Dr. Mritika, excellent video. In your first video, in case of retinoblastoma, is it instead of bipolar, if you cut by bipolar muscle, if that unfortunately that muscle, there is an early involvement on that particular muscle. So just not for you, but other for Shraddha Sanobar sir.
Right.
For other those, suppose your oncologist or your retina specialist is not so tuned to tell exactly, in such cases better we can use the scissor.
Absolutely, sir.
Instead of that take home message, if you are confident, so that's the thing, up to that mark, that muscle is not perfectly involved, and in such cases.
Absolutely.
But for in general surgeon, the scissor one. Second, are you prefer evisceration or enucleation? For a say painful blind eye, what is there is a uveitis in the other eye.
So, in that case, after having ruled out all, if there's no intraocular pathology as such, evisceration works well unless we are, if the patient is at a risk of sympathetic ophthalmia, in which case we would then go for enucleation.
Sympathetic ophthalmia, as per the literature shows, even that trauma 7 days old,
Absolutely.
there may be a possibility at any time.
Yes.
So my view is that if there is a uveitis also, if you are not so much confident, it is a case of a sympathetic ophthalmia, already old case, long-standing case. Recently I operated one case, explained to all. So if I do a enucleation also, is not possible to prevent if anything, and there is a chronic uveitis. So if you want, then we can go for evisceration,
Yes.
otherwise you can. But enucleation is not so easy in all that time.
Yes.
There may be a migration.
Absolutely.
Migration of ball especially.
Yes.
And other ball, there is a lots of issues. Thank you.
Yes.
Very excellent talk.
Thank you, sir.
If you have any question from the audience, then for shortly 1 or 2 questions. Okay.
Thank you so much, Dr. Mritika. Now we move on to the next talk, that is implant exposure and prevention to cure. And I'd like to invite Dr. Rutuja Thomas to do the needful, and she's from Delhi Vision Eye Care. Over to you, Dr. Rutuja, please.
Thank you, Dr. Sonam, and I thank Dr. Fairuz for including me in this session. So I'll be talking about implant exposure, and right at the outset, I'd like to mention that the incidence of implant exposure is declining. I don't know if this is documented in any way, but just over the past 6 years, from when I started fellowship to now in practice, we are seeing less and less of implant exposure, and maybe we can have an ocularist perspective also on that. So I'll be covering it under these topics. So implant exposure mainly presents like this. This is a porous implant. You can see that the surface is exposed, and you can see the inflamed and retracted conjunctiva around it. So what are some of the causes for this? Intraoperatively, it could be actually the cause for the evisceration. Was there any melting of the sclera? Was there any other inflammatory issues? While putting the implant inside, was it placed too far forward? Was the closure of the anterior tenon capsule not meticulous, the way Dr. Mritika had shown? Was it not like that? And any irregular surface of an implant can mechanically erode through the conjunctiva. That's important to remember. So the size of the implant, of course, like she mentioned, -2 from the axial length. The tension at the time of closure is very important. It's important to also use a sizer, even if you've decided on a size of an implant, use a sizer intraoperatively, because if it's oversized, you can have the extrusion very early. Now, the implant itself, the older implants, hydroxyapatite and porous polyethylene implants, they were prone to exposure because of the dehiscence, and even after a slight exposure, they would need removal because they would get infected. Now, the additional methods that were used earlier, like wrapping the implants with polypropylene mesh, was also associated with exposure and very difficult to treat, but less exposure with wrapping with sclera. The pegging of the implants for motility was also noted to result in exposure. Now, certain prosthesis factors also are important, whether the prosthesis was poorly adapted, that is rough on the surface or sharp edges. Was there any prolonged conjunctival trauma resulting from that? Any inflammation and thinning subsequently leading to exposure? Now, the initial use of a conformer in this situation is very crucial, and the maintenance of the prosthesis is also important. And it's good to have a good ocularist, and my great ocularist is there in the audience, so it's good to have somebody who you can keep in touch with for these things. So post-operative causes, I've listed it as 6 Ps. That is post-operative infection that can develop at any time post-operatively, poor wound healing, poorly fitting prosthesis, any pressure points that are present between the implant and the prosthesis, poor blood flow due to a variety of causes. Any pyogenic granuloma could also be suggestive that an implant may expose later on. So poor wound healing factors include any cicatricial conditions or any radiation exposure, so it's important to factor in these causes while you're assessing an implant exposure. So this is a typical case of implant exposure where you can see the discharge also accumulated. This would typically require a removal and a period of waiting for the infection to subside, maybe even send a culture and then do a secondary implant later on. This is an exposed silicone implant. Here you see not too much of congestion and not too much of discharge present here. So you might actually be able to re-implant a smaller implant and get away with that. So each case is different. And this is another implant exposure, a patient who had a porous implant who waited quite some time before coming in. So he finally developed a kind of contracted socket, and this is probably just the leftover wrapping material actually which is left behind, and a small part of the implant. So these kind of implants, they tend to sort of disintegrate as well if a large part of it is exposed. So in such patients, you can go ahead and do a secondary implant, or in this case of a very contracted socket, we did a dermis fat graft and he did well. Now, some patients can have a complete extrusion that it's completely melted and the implant is not even present there. In these cases, you would need a secondary implant. So if implant extrusion or exposure is not treated adequately, you can have other eyelid malpositions which develop. And the major management is that if there is no infection, you can do an early secondary implant, and that helps to, again, reduce the contracture later on. If there is an infection, wait for the infection to settle, do a culture and treat the infection. If there's too little of a cover when you're planning for surgery, you can use an MMG or a scleral patch graft. And if the volume is also inadequate, you can do a dermis fat graft. If the fornix needs to be assessed, you can do a fornix forming suture. So this is just an example where you have an exposed implant, you have to go all around the implant, dissect the conjunctiva off, and you can implant a scleral patch graft like this and try to cover the patch graft as far as possible with the surrounding conjunctiva. Now, a scleral graft is usually sandwiched between the tenons and the conjunctiva to decrease the chance of scleral melt post-operatively. And you can also do a dermis fat graft, and this is a case wherein it's also been done with a fornix forming suture. Now, there is a new study wherein there is this little change in the thought that even if you have an exposed porous implant, because if there may be any kind of monetary issues, you can actually take that implant, rotate it, and then re-implant it with the non-exposed side, that is the side which had the maximum sclera covering it. So this is something that we can think about. And that's all for implant exposure. If any questions, I would be happy to discuss. Thank you.
Yeah, it is excellent. But nowadays there is a trend. We observe more exposure on porous. Are you prefer still porous implant?
No, sir. We only use PMMA implants.
The take-home message is this: that porous implant, if that is quality is not good, whatever quality, there is a chances in long standing also more exposure. So better, even if we compare in one of my studies, this silicon versus acrylic. Acrylic works better, less infection with silicon. And most of the time, generally in our colleges, it was mentioned, it was always done in a minority. Minority means infected OT. That's not the protocol actually. In a oculoplasty, we can just popularize the technique. If there is no chance of infection, ultrasound, it is a painful blind eye trauma case, better we can go ahead in a clean OT with a good illumination, good microscope. They term as a major OT, one minor OT. Oculoplastic surgeons always mention in other hospitals a minor OT. Whatever orbitotomy, if you don't, the receptionist will, are you doing in a minor OT? So that's the point. So we want to eliminate that part, then we can do lots of work. So that's one important.
Can I just comment here? Very good comment thing which you said. So worse than minor OT is, some people call it septic OT. No OR can be septic, right? Every operation theater that you operate is aseptic. So there is no concept of a septic OT. We oculoplastic surgeons, we always operate in an aseptic OT.
I am working in some hospitals where that a culture growth in septic is less in compared to the phaco OT. That's the true. This is the true factor as per the report I am showing. So this is our phaco OT culture report. This is the septic OT culture report because we are taking more care.
I think this is what we all face, intraocular surgeries versus extraocular surgeries, and invariably we're termed as, operating in septic OTs.
It is also acceptable, intraocular surgery or cataract surgery OT, but if someone asking labeled you as a minor OT surgeon doing orbitotomy, it's not acceptable.
Yeah, we can start a petition.
All right, thank you. Thank you so much, Dr. Rutuja. That was lovely. And over to the next talk. It is, I think, every surgeon's nightmare, contracted socket. So I'd like to invite Dr. Sonal Yadav from Pune to tell us about the challenges and strategies on how to manage a contracted socket.
A very good afternoon to all. Thank you so much, Dr. Sonam, for the kind introduction. So after hearing two excellent talks about the primary surgery regarding eye removal, that is evisceration and enucleation by Dr. Britika, she beautifully summarized the key points of doing an ideal eye removal surgery. And also an important talk by Dr. Rutuja regarding the implant exposure and touching upon the important points which, that makes my job a little bit easier. So now coming to contracted socket. So what happens if the primary surgery, enucleation or evisceration has not been performed properly or has undergone some amount of complications? We sometimes might lead into situations like these. So a couple of cases. The first young lady was operated for a case of retinoblastoma at a very young age of 2 years. However, no implant has been placed and she has not been using any anterior conformer or ocular prosthesis, either stock or custom. So she has now ended up with a grade 3 to 4 contracted socket. The second young lady presented with a congenital enophthalmos and a congenital hypertrophy of the unilateral face. Or sometimes we are also faced with such conditions where this young man underwent enucleation for retinoblastoma, but because of high risk factors on his histopathology, underwent radiation afterwards. And though having been performed a very good surgery, post-radiation he did have some complications leading to symblepharon and band formations in his fornix, and thus leading to a contracted socket. So thus not able to retain his processes properly. So we are many a times we are faced with these situations, and so the pendulum for management of contracted socket goes from highly rewarding to highly frustrating for even a surgeon and the patients as well. So the key point here is customizing your approach, evaluating the patient well, and finding out the exact points that can be corrected, and then using the permutation and combination of techniques we have in our Oculoplasty toolbox to correct them either in a one sitting or a stage-wise approach. So, in a nutshell, the anophthalmic socket can either be primary congenital along with an anophthalmos or microphthalmos, or can be secondary post-primary eye removal surgeries. So what do we want in an ideal anophthalmic socket? So successful anophthalmic surgery is when the anophthalmic patient obtains a painless, non-inflamed eye socket with adequate volume restoration and an artificial eye that looks and moves almost as normal eye. So we need a centrally placed, well-covered, buried implant of adequate volume, preferably for bioinert material, a socket lined with healthy conjunctival epithelium and deep fornices, a normal position of eyelids and well-directed lashes, symmetrical supratarsal fold with the contralateral eye, a good coupling and transmission of motility from the implant to the prosthesis, and a well-fitted symmetrical ocular prosthesis. So we'll cover a little bit of evaluation of socket and the algorithm to manage the individual grade and level of contracted socket. So, a very, very important aspect to go from the thorough history evaluation to find out the cause, if it is a congenital condition or an acquired one, and also looking at the primary etiology regarding trauma, infection, or tumor. The surgery performed and the adjuncts to the surgery are very, very important, whether enucleation, evisceration was done with an implant or without, and the kind of implant, and the status of the implant currently, and very importantly, radiation in the past. Apart from that, very important history is a process-related history, whether the use of processes has been continuous or not, or has not ever used the processes, the duration of processes, and also the fit and maintenance. So I'll just touch upon a few of the points in evaluation of the socket. So the first thing you always notice is the facial asymmetry. If it has been a long-standing condition, you also might end up with a patient who has these malar hypoplasia and showing the entire hemifacial atrophy. Next, you might, like in her case, where the enucleation is formed without placing an implant, you also see a superior sulcus deformity, which is a part of post-enucleation socket syndrome because of the migration of the orbital tissues in a particular way. Also, some of these patients will also present with enophthalmos, either enophthalmic or microphthalmic sockets. So the sign of volume deficiency is due to probably because of a smaller implant if prior operated, or an absence of an implant can be measured. Next, you always see the position of the eyelids, either with the process, if it is a mild, moderate, or severe ptosis. Evaluation of eyelid in detail regarding the inflammation, possible blepharitis, laxity or shelving of the fornix, or eyelid retraction. And always examine the eyelids without and with the processes to exactly know what is happening to the eyelids when the processes is put into place. Followed by that, we have evaluation of processes, look at the position and the fit, the movement of the processes, and the quality that includes the surface, any deposits, and edges. After the processes, you can evaluate the surface. Sometimes they might have a varied presentation with multiple symblepharon or band formations, followed by evaluation of the fornices. So if simply eye closure and eye opening test with the process in situ will let you know if the fornices are adequate or not. For example, in this particular patient, definitely on eye closure, the eyelids are not moving, so she does have shallow fornices. Evaluation of socket volume, we have covered this in the prior talk, so I'm not going to comment upon the sizing of the implants. Imaging, particularly important in cases where you are also suspecting bony contracture, in case of congenital issues, or in in indications like implant migration, malignancies, traumas, or fracture. So basically, contracted socket is a shrinking, presents with a shrinkage and shortening of part or all of the orbital tissue, causing decreased depth of fornices, orbital volume, and ultimately leading to inability to retain the processes. So either an absence of implant migration, extrusion, ill-fitting processes, multiple socket surgeries in the past, burns or radiation to the ocular surface, or congenital pathologies can lead to these contracted sockets. There have been myriad of classifications used, but the commonly used proudly we use the Gopalakrishnan classification provided, and I think this gives a more extensive view and gives a more better management protocols when used. So includes grade 0 to 5 depending upon the levels of fornicial contractures. Barron-Smith contracture is basically a little simpliform from mild to malignant depending upon the fornices. The Gubor morphological classification is more of an etiological classification, includes enophthalmic, ophthalmic, microphthalmic, and hypoplastic. So looking at grossly the assessment of socket, you look at the surface loss and volume loss, or if it is a combination of both. So, indeed, a little bit in detail regarding assessment of surface. So, your surface comprises of a superior fornix, palpebral surface, and the inferior fornix. So, approximately these are the measurements your fornicial conjunctiva and bulbar conjunctiva should be getting. So, depending on that, you can either use fornix formation sutures, amniotic membrane grafts, mucous membrane grafts. I will just summarize. I think Dr. Sonam is going to speak upon the grafts in detail. So I'll summarize with this particular slide, which provides a management algorithm depending on shallowing of fornix, surface loss, and volume loss. So if you have mild to moderate and severe surface loss, fornix formation sutures with adequate graft, either amniotic membrane or mucous membrane works well. No surface loss and volume loss, you can go in with a secondary implant. Along with surface loss, you can combine it with a secondary implant and a mucous membrane graft or a dermis fat graft. A severe contracted socket may need exentration processes or vascular pedicle grafts. So a well-formed socket can be fit with a custom ocular processes. A congenital microphthalmos case can have a serial conformer expansion of the conjunctival fornices and can be fitted with a adequately sized custom ocular process after surgery. Amniotic membrane grafting gives
I'd request you to please conclude, Dr. Sonam.
Yeah. So, in a nutshell, it's an uphill task to, manage a case of contracted sockets. It requires a lot of patience on both the surgeons as well as the patient's end, and there is no one-size-fits-all. It's always a customized approach. A single or a multi-stage surgical procedure followed by custom ocular process fitting gives very satisfactory cosmetic outcomes. And though last point, however, a very important point, a role of ocularis is immensely important in managing all the cases of contracted socket. Thank you for the opportunity, and if there are any questions, we'll take them later.
Thank you so much, Dr. Sonal.
I request you now to Sonal, in such cases, you can sit here and one of the big culprit for contracted socket is the stalk eye. Most of the time, this is therefore I am sharing with that a young ophthalmologist. If you do an evisceration, enucleation, whatever in a very nice way, but if you fit a stalk eye, that means after a few hours, whatever way, there may be a contracted socket. So first cause is the contracted socket. Sonal nicely mentioned all. Just I want to add one. If we want to treat the contracted socket, first we have to know that is it due to the infection, underlying infection that cause, or it is a vascular cause. If there is a vascular cause, and we can find it out one by one. From the systemic cause, sometimes there may be so many issues. So we can find it out, then we can go ahead as by Now we can start.
Yes, thank you. Thank you so much. And my topic for today is grafts in a contracted socket. And thank you, Dr. Sonal, and all the speakers before me for making it more easy for me. So the goals of an anophthalmic socket is very clear and has already been discussed. And yes, the most commonly used classification is the Gopal Krishnan classification of a contracted socket. Now, when you look at a contracted socket, it is very essential to ask for a proper history and assess clinically. Why? Because you need to not just look at the soft tissue contracture, you also need to look at a bony contracture in cases of congenital anophthalmos or any injury in childhood. Soft tissue contracture, as very well mentioned by Dr. Sonal, mainly we look at the volume, we look at the surface, and very importantly, we also look at the surface lining. You have to look at whether the socket is moist or it is dry, and Schummer's definitely helps here. So, as etiology is already mentioned, it can be congenital, it can be iatrogenic, it can be malignant because of multiple injuries. Now, as you look at this, these are the three most important things as I was just stressing on. One is volume. Second is the phonesis, that is the posterior lamella and the lining. And third, we should not forget the anterior lamella, the periocular tissue as well, because that is also very important in assessing while you want to plan and give the patient a very good cosmetic outcome. So, well, we have multiple grafts that you can use in a contracted socket, depending upon whether you want volume, you want surface, or you want volume plus surface. So for the surface, you have the mucous membrane graft, which can be taken from the lip or the buccal mucosa. You can use an AMT, which is a substrate graft, that is the amniotic membrane graft. And for the lower lid, of forming the phonesis, you can actually use the spacer graft. You can use a hard palate graft, spacer graft, or you can even use a free tarsal from the upper lid. If you have like a very malignant, contracted, dry socket, many a times you can also line the entire socket with a skin graft. It can be a split skin graft or it can be a full thickness skin graft. And for the volume, dermis fat graft is very beautiful. It's a composite graft which can give you the surface as well as it can give you the volume. Yes, you have autologous free fat graft also, which gives you good volume. Along with that, it also enhances your periocular skin. You augment it with PRP and the results are beautiful there. And if nothing else works, yes, we go ahead with free flaps and microvascular free flaps. So coming on to the mucous membrane graft, as I said, we normally harvest it either from the lip or you harvest it from the buccal mucosa. It is very important that you do not cross the midline A, and B, when you're doing it from the buccal mucosa, there are two things that you have to keep in mind. One is the position, the second molar, and you should not damage the parotid duct that is there. You get a very good clamp that you can actually clamp the cheek with so that you have a very good hold on to that. Measure the socket depending upon how much defect you have. Now, mucous membrane grafts can be done in two ways. One, you either line completely in the center and expand the tissue so that your actual tissue which is there goes off into the phonesis. Or second, you do it independently into two layers. You form the inferior and the superior fornix separately as well. It is a surgeon's choice. So here, as you see, this is a case of a grade 3 contracted socket. We have superior as well as inferior phoneal contracture. You also have a volume deficit here. So what we've done is we've taken a central incision right at the center and placed a nice big MMG for this patient. You can see here there is this inferior phoneal contracture as well as a superior phoneal contracture, and this is the patient post-operatively. You can see there's still a little volume loss. You can see superior sulcus deformity, but the patient is doing much better and is able to retain the shell. Here, this is another patient with a congenital anophthalmos. As you can see that we've been giving her conformers, serially enlarging conformers, and then finally she's come to the stage. We've done a ball implant here, and if you see for the superior and inferior fornix, we've done a small MMG superiorly and inferiorly. Finally, she's able to actually retain the prosthesis here. Now, another case where you just have a grade 1 or a grade 2 contracture, you can actually just incise in that area, put a nice AMT, and take superior fornix forming sutures or inferior fornix forming sutures as well. Now, here is a case where you can see that there is a little bit conjunctival hypertrophy and shelving of the inferior fornix. It is a case of grade 1 contracture. You can see that there was a lower lid retraction here, as well as there's a very subtle hypo here. So what did we do here? We just took an autologous free fat and we injected into the lower lid and a little bit into the orbit. You can see that the lower lid retraction has beautifully been early. While I was going through the literature, I also came across a very interesting article where they've actually used a scleral graft to line the surface so that it improves the surface lining, and they have then allowed allowed the sclera to heal. At 2 weeks, they've given and subjected it to low-level laser therapy so that it enhances the healing, and you can see the beautiful result here at the end of the procedure at last follow-up. Now, dermis fat graft, as I was mentioning, is a beautiful graft. It's a composite graft which can also give you surface as well as it can give you a good volume. And the indications are definitely in a contracted socket where you have a previous implant exposure or a malignant socket. But most importantly here is you have to have a good vascular bed. If you have a good vascular bed, your grafts will take up. So the procedure is pretty simple. You have multiple sites where you can harvest the DFG from. It can either be from the abdomen, it can be from the gluteal area, or it can even be from the forearm or the inner aspect of the thigh. So we normally use a gluteal area, and we have a limitation there because the height we can go only up to the 20 millimeters, because post that you have the gluteal muscle, and 20 into 20 is the ideal size that you can take for the surface. Now if you want more volume, you can go in more obliquely and you can take more fat which is there. The surface need not be very large per se. Once you have done that, you can take an incision right in the center as shown here in the diagram, harvest it and then suture it. Wait for it at least for about, DFG normally takes about 3 to 4 months on an average to epithelize. Now here is a case which was a non-epithelizing DFG. It was 6 months post-surgery, still not epithelized. And look at this here. We just added PRP drops topically and the epithelization just accelerated. Another thing that can happen in pediatric age group with the DFG is you can have a hypertrophy of the fat, which is seen in this patient. You can see there's proptosis and down rolling of this prosthesis. Here you just debulk the DFG. Many a times you can get fat necrosis, you can get fat atrophy also, and we must be prepared for it. Normally we harvest about 10 to 20% more of the dermis fat graft. While going through the literature, I found something very interesting where you can do a composite graft, harvest the hard palate along with the dermis fat graft, so that way you can form the fornix as well and give volume also into the socket. So we tried the same on this patient. You can see beautiful result. She's retaining the prosthesis very well. The entropion as well as the lower lid retraction is well taken care of. Here is another example of a patient post DFG and LPS plication, and look at the result. It's quite beautiful. Now I'll just quickly run through this video of autologous free fat because I think it does wonders when you have a volume deficiency. Also for the periocular skin, it actually enhances the periocular skin, gives a very good cosmetic outcome. We normally take it from the abdomen. We just take a small incision, use Coleman's dry technique to actually harvest the fat, and by centrifugation, we let the fat settle down and separate the serum from the same. And once the fat is ready, you can inject it into the periocular area as well as into the socket. Depending on where you want to inject, you can either inject into the deep lateral or you can inject into the medial conal space in order to augment the volume. As you can see here in this patient, she had a volume deficit. After AUFG, you can see that there is good increase in the volume here. Like I was mentioning, you can do split skin grafts in case of malignant socket.
Dr. Sonam? Yeah.
Yes. I'll conclude with that. You can do multiple flaps also. Just a take-home message would be not to forget your orbital anatomy also and your bony contracture. And yes, assess the socket history, and please, we need to give a realistic picture to the patients and have a good ocularist hands-on. I'd like to thank, these are my acknowledgements. And I'd like to invite everybody to please come for TNOA, which is happening in August. Thank you so much.
Thank you, Dr. Sonam. That was a wonderful talk regarding very important tools in our toolbox as an oculoplasty surgeon for managing sockets. Now, moving on from talks regarding ways to retain the processes to how to correctly manage the processes, I'll hand over to Mr. Sachin Gupta to talk about ocular processes.
Yeah. Good afternoon, everybody. I will be talking on ocular prosthesis. Somehow this is not working. Excuse me. The finishing touch. I have no financial interest from this presentation. I will be covering these topics based on the indication for ocular prosthesis. The first indication is thisis bulbi. Probably this is the favorite case for ocularists because we can provide good results in these cases. Patient gets best movement in thisical eye, and these cases are less manipulated by surgery. And even we can fit a prosthesis where there is a clear cornea. We can create a corneal vault behind the prosthesis, and we can do fenestration for better tear exchange. And such patient also get a good prosthesis even without the surgery. The next is anophthalmic cases, post-enucleation or evisceration, where implant is must, and it's very important. So from Ocular's point of view, when we are creating a prosthetic eye, we need at least 2.5 milliliter volume to make a 3D prosthetic eye, where we can have an anterior chamber in the prosthetic eye. So the remaining 4 to 4.5 milliliter volume should be augmented by the implant, and if we convert this according to the implant diameter, so in our perspective, 20 mm implant is a good size to create a 3D prosthetic eye. Implant size is very important. If it is oversized, then we have to create a very thin prosthesis, and which can cause rotation in the prosthesis. It can rotate clockwise or anti-clockwise, which is a problem. Then we have to compromise with anterior chamber depth in the prosthesis. Sometimes there is an upper lid retraction because of the oversize of implant. If the implant is undersized, then it can cause enophthalmos or post-enucleation socket syndrome. The prosthesis will be thick and bulky, and movement of prosthesis will be restricted. So if you see this case, this patient had an implant of 22 millimeter size. If you see this result, here the upper lid, there is a retraction of upper lid. This prosthetic eye looks little bigger than the fellow eye. Conformer is very important after the surgery. Appropriate size of conformer is must. So when on table, when you are putting a conformer, the largest size conformer is better, but it should be easily moved horizontally and vertically inside the socket. In case of tarsorrhaphy, if you are planning to do a tarsorrhaphy post-surgery, at least it should be removed 1 week prior to the prosthesis fitting, because it can compromise the fitting of prosthesis. And painted conformer is a good option, which can be advised after 1 week of the surgery. Instead of transparent conformer, patient get a painted conformer. So this is an example. This patient, she got a painted conformer after 7 days of surgery for the healing period. And we had 4 holes in this painted conformer for a better tear exchange and eye drops installation. So this gives instant cosmetic rehabilitation post-surgery. The third indication is congenital disorders like microphthalmos, where we put expanding conformer. We prefer to put a custom conformer from day one, because impression gives us the exact idea of space and dimension of the socket. We can use this information and we can uniformly expand the socket. Stock conformers in early age may cause uncontrolled expansion, so we do not prefer a stock conformer for expansion. Custom conformer can help in expanding horizontal fissure light, which is very important in expansion from day one. So these are the stock conformers. And then we have pebble-shaped conformer, which is made after taking the impression. And now, from 2018 onwards, we have the conformer which has a wedge on anterior surface. So why we have wedge. So I'll explain. When we take impression, we convert this impression to a conformer. But sometimes, in some cases, this conformer rotates clockwise or anti-clockwise. So what happens? The conformer which we want, it should stay like this. But when it rotates, so it gives under expansion at the desired area and over expansion where we don't want. So these wedge implants it prevents the rotation, and it also helps in horizontal expansion. We have controlled horizontal expansion through this wedge. So this was the case which was treated with the wedge-shaped conformer. So coming to the prosthetic contact lens and prosthetic shell, prosthetic contact lenses are indicated for discolored eye, not for the disfigured eye. And prosthetic contact lens cannot correct enophthalmos, squint, or any discoloration of the sclera. It is only for the cornea. So this is a case where a contact lens was given to the patient, but this was replaced with the thin scleral shell. We have next case, orbital prosthesis, where silicone prosthesis, which is adhesive mounted or spectacle mounted, are given to the patients. Silicone prosthesis, which is adhesive mounted, is directly attached to the face. And then we have recently developed a prosthesis which is called digital spectacle orbital prosthesis, which is created by taking digital picture of the patient's other eye. So I'll explain, like we have taken a good quality picture of the patient's other eye. We use it like with the help of software, we flip it, we take print with different brightness. And this print is varnished to protect it from UV light. And then this is laminated with heat cure acrylic so that we can prevent from the water also. So I'll just skip the video. I'll show the direct result. This was a digital spectacle prosthesis. This prosthesis can be given in any given case. Like here, she had a complete ptosis, and her daughter was getting married after 1 week, so she was looking for an instant cosmetic rehabilitation. This case, she got the prosthesis post mucormycosis. This patient got prosthesis for severe contracted socket, again for mucormycosis. About the care and maintenance, the prosthesis should be removed as per the convenience of the patient. If it is comfortable, patient should not remove the prosthesis. External factors like dust, dryness, humidity, AC vents, these are the factors which cause dryness in the prosthetic eye, and patient can clean it after 4 to 6 weeks. But if they feel that it should be clean after 1 or 2 weeks, they can clean it. It can be cleaned with mild shampoo, like baby shampoo and water, because we just need the surfactant. We don't need chemical to clean the prosthetic eye. Custom prosthesis can be soaked in RGP solution if it is required and cleaned with the water. There is a 3-phase model for prosthetic eye wear. When we put a prosthetic eye, what happens? Then there is a mucus substrate distributed over the prosthetic eye, and then we have equilibrium phase, which it lasts from 4 to 8 weeks, where there are a lot of deposits covers the prosthetic eye, and it helps the socket to adopt the prosthesis. But then we have a breakdown phase where there is a lot of deposit over the prosthetic eye, and which can cause calcification over the prosthetic eye and the protein deposit, which can lead to GPC. What is the next level? I will explain. There are a few recent advancements. Digital printing of iris, where we take the digital print of the natural eye, and it is used to make the prosthetic eye. Next is 3D printing of eye, where the iris can be scanned and it can be 3D printed and it can be used in the prosthetic eye, which we have already started using. Just few seconds. Hydrophilic artificial eye. Artificial eyes are made by such material which is hydrophilic, which is not water loving, but we can create a hydrophilic artificial eye now. Thank you.
Thank you so much, Mrs. Sachin. I think no matter how many surgeries we do, without your support, I think our outcomes are always guarded. Anyways, now I'd like to invite Dr. Nidhi Pandey to please come up on the dais for her case presentation.
Good afternoon. Hi, Sonam. So after all those contracted sockets, I'll be talking about a case of extra socket room. How can that be a problem? Let's find out. So this was a case. So a 40-year-old gentleman complaining of depressed or a not symmetrical looking right side of the prosthetic eye and the periocular region. And he had a history of trauma and wearing a prosthesis after that with no previous records. So we didn't know what exactly happened. All we knew was that he had an accident and he's lost an eye. So we presumed this to be, what would you presume it to be in the face of it? It looks like a contracted socket, okay? That's what we presumed it as. And then we saw that it's actually an expanded socket instead of a contracted socket. But yes, it leads to a prosthesis which is not moving, and an enophthalmic looking ophthalmic contracted socket is something that I'll call this. So this is one of the causes of enophthalmic and ophthalmic socket, where because of the expanded volume, your prosthesis is enophthalmic, okay? So what we did was a 3D printed model of the skull, and this is the right orbit. And then we had this template of the prototype of the implant that we were trying to make, and then a titanium titanium prefabricated implant was made and fitted on this 3D model to see how it fits. So we went ahead with the orbital floor repair. At the same sitting, we did an evisceration with implant of whatever residual eye was there. And this is how the volume looks filled immediately after the surgery, and this is after the custom-made processes made by everyone's favorite Sachin. And these are the post-op scans where we see the prosthesis in place, the implant covering the defect, and this is the 3D reconstruction. There was one more slide here. Sorry, so there was one more slide citing literature evidence of why a 3D based orbital implant works well in preventing multiple attempts of putting the implant and being very much prepared well ahead and before the surgery of how we'll go about the kind of incisions we'll put that implant, and obviously the results are more predictable. So thank you so much. I'm sorry for that.
Thank you so
slide
much,
missing in my
Nidhi.
presentation.
That was really a nice, interesting case. And I think in the interest of time, we conclude. We're so sorry for taking a little longer. Thank you so much. And I think all of us can take a picture down while the next session starts. Thank you so much, Dr. Feroz.
Thank you, Sonam. Thank you, Sonal. Thank you, Mritika. And thank you, Nidhi, everyone, for this wonderful session on socket. And thank you so much for the time.